Afternoon, everybody, and thank you very much for taking time out of your busy days to come and attend this PPMA webinar. I'm Marie Metham, and I'm a strategic HR business partner with Lincolnshire County Council, and I'm also a member of the PPMA Extended Management Board, and I'm your host for this afternoon's webinar. So you'll probably be aware this is one of a series of webinars that PPMA run, and we try to bring you thought-provoking topics from a wide variety of different speakers. And today we are delighted to be joined by Jane Graham, who's Associate Director, System Development in the People Directorate of Somerset Integrated Care System. And she's going to be talking to us about how to demystify the integrated care system. So just before I hand over to Jane, just a couple of housekeeping things, just to make you aware, the session is being recorded today, just so that anybody who can't join us, and obviously numbers might be small, we know it's half term in some parts of the country, anyone who can't join us today can get the webinar on catch up, so they can still get access to the content. So as I say, it is being recorded, but don't worry, it's just myself and the presenter that will be visible on the recording. So you can keep your camera on if you want to, that's entirely your choice. But if I could just ask if we can turn our microphones off during the presentation, and there will be questions, opportunity for questions at the end, or if you'd like to, as Jane's taking us through the presentation, you can also put questions in the chat. So really looking forward to today's session, and without further ado, I'll hand over to you, Jane.
Okay, thank you, Marie, for the introductions. So as Marie said, I'm Jane Graham. I'm one of the Associate Directors in the People Directorate for NHS Somerset, or the ICB, but I'll demystify that in a second. Just to say that I've worked across the integrated care system for about 3 years now. But my previous life was working for the NHS Trust in Somerset. But the majority of my career has been in local government, actually, and I've hopped between Somerset, Cornwall and Wiltshire. So Clive, good to see you today. I know Clive very well, and I probably know others if they're joining later. Apologies if any of you have also attended the workshop I delivered with my director last year at the PPMA conference. You might recognise some of the slides, but there's a lot of content that is new. So what I hope to do is give you a quick guide to those often confusing acronyms that the NHS tend to use. But I was thinking about that. I was thinking local government's not far behind, actually. So what's an ICP? What's an ICB? What's an ICS? And what I'll do is I'll talk a little bit about Somerset to help put those terms into context, including what our workforce looks like and the significance of it. I'll cover the why bit. So why should you know about this stuff, and why should you get involved if you haven't already? And finally, if I have time, I hope I do, I'll highlight where we're working together on some system workforce projects, which I hope will make the case for collaboration and involvement very clear. I plan to present for about 20 minutes. I really want to kind of leave a good chunk of time at the end for any questions. And don't worry, no question is silly or daft. Please go for it. As Marie says, use the chat. I can't see the chat as well as presenting, but maybe we'll pick that up at the end. But first, if it's all working correctly, and you have to tell me, I've got a bit of a Menti, and I'm going to move it over here because I couldn't work out how to embed it in my presentation. So you've got the Menti code there. If you can join it, I just want to get a take on your understanding of where would you rank your understanding of what an ICB, ICS and ICP is. Can you all access the Menti? It'd be great because I think the results will be coming up. I'm going to give it about 20 seconds or so. Shout out if you can't access it.
Hi Jane, it's Clive here.
Yeah.
A silly question. How do I access it?
So if you go to menti.com.
Cool, and just stick the...
Yeah, there you go. Somebody started. Yeah, stick the code in. It should take you to it. I've got one. I'm hoping not everybody's going to put themselves in help get me out of here. Everybody having a go? Give it another 10 seconds or so. Good to see Martin Reddington.
Me. Thank you very much.
That's all right. I've only got 2 votes so far, so it's either you can't access it or you're a bit oh, most of it. I like that. Okay, that's given me a bit more reassurance. Okay, I'm gonna take this. I'm gonna take this off our screen, but I will still keep an eye on it. So if you haven't had a chance to vote, still do. So 2 people have said most of it. If I put it back again, you might be able to see it. People still have some questions, which is really great because that's the whole point of the webinar. Okay. So let's move on. Oh, there's the QR code. That would have been helpful. So I'm going to spend quite a bit of time on this slide because this is kind of the underpinning kind of topic for this webinar today. So really helping understand what these terms mean. If I start with the ICS at the top, ICSs have actually been around for a few years. It stands for Integrated Care System. They've been around for a few years, probably in a more voluntary kind of state. They were formally constituted and recognised in law within the Health and Care Act in July 2022. In the Health and Care Act, it also passed other things like the Oliver McGowan training, which you might be attending or have attended. So there's quite a few things in that act. What this did was it saw a fundamental shift in the way the health and care system was organised. I think there was a recognition that more needed to be done and around collaboration, convening and integration. And that's what the Act really kind of spelt out. So there was a very much an expectation that integrated care systems would do that, working with local populations to drive forward improved care services and health outcomes. The purpose of the ICS was also outlined in the Act, and you can see that in the wheel on the left-hand side of this slide. That's actually lifted from the King's Fund. If you don't know about the King's Fund is a kind of policy-making quasi sort of government body, I would say, probably. If you go onto their website, they have lots of really interesting blogs, papers, research papers. They really put things into very simple terms. So a lot of what I'm saying here, actually, you'll find on the King's website. So there's 4 purposes of an ICS. So they are improving outcomes for population health, tackling inequalities, enhancing productivity and value for money, and supporting that broader and economic development piece. So it's important to recognise that the ICS isn't an organisation. It's not an employer. What it is a collection of organisations and partnerships that work across what is called a footprint. So you might have heard that spoken about in passing. There are 42 ICSs in England, and each ICS is quite different. Some are quite big and complex, like Greater Manchester, for example, Yorkshire and Humber. Some are quite small, like Somerset. So Somerset, I think, is one of the smallest ICSs across the country. So by complex and big, I mean, some have more NHS trusts and services. Some can have many different kind of local authority arrangements, for example, county, district, unitary, metropolitan. Some can have varying sizes of social care providers. We all have different volumes and numbers and sizes of social care providers, voluntary community sector, community groups, etc. But their fundamental purpose is the same. So all 42 ICSs will be working towards the same purpose. An ICB, on the other hand, so if I move down, is an organisation, is an NHS organisation, and there is only one ICB for every ICS. So that's quite important to know. They're a legal entity, an employer, and what they did was they absorbed the formal clinical commissioning groups, or CCGs. I didn't want to bombard you with another 3-letter acronym, but they absorbed the formal clinical commissioning groups in each footprint. And again, in some areas, there was more than one CCG. So when the ICBs were created, they had to merge CCGs. In Somerset, we were quite lucky. We had one CCG. So in effect, what happened when the ICB was formed last year is that we lifted and shifted all the staff into the ICB. What ICBs do, though, is they carry out the commissioning and contractual arrangements with NHS providers. So that means the hospitals, mental health trusts, etc. in the ICS footprint. And they also pick up some additional commissioning activities that was previously held by NHS England before they were formed, for example, in dentistry and community pharmacy services. There is an expectation that the ICB will carry out joint planning with the NHS and local authority, and they are directly accountable to NHS England for a range of performance and NHS spend. Performance it's quite a massive undertaking, so we're talking here about things like waiting lists, how many ambulances are outside queuing outside a hospital, how quickly people can see a cancer specialist. You know, there's a whole plethora of performance measures that actually the ICB have to report to up to NHS England. Hope I'm keeping you so far.
Yeah.
I'm glad somebody mentioned that. With an ICP, an integrated care partnership, it is a partnership. Again, it's not an organisation, it's not an employer. It's a statutory joint committee of the ICB and the local authority or local authorities in the area. So it brings together a broad set of system partners that include health, the local authority, but also police, housing, fire and rescue, Health Watch, voluntary community sector, for example. So it's a very big, broad set of partners. And what they do is they support that partnership working to develop what's called an integrated care strategy. And I'll talk to that in a second. The strategy is the plan to address the wider healthcare, public health and social care needs of the population in that area. And the strategy must build on the local joint strategic needs assessments and the health and wellbeing strategies, and must be developed with the involvement of local communities and Health Watch. So the plan is a statutory plan that we have to have in an ICS. It has quite a significance. So the ICB, the Integrated Care Board, has to have due regard to that plan when making their decisions. The ICP, unlike the ICB, doesn't directly commission services. So it's very much about delivering and overseeing the delivery of that strategy. In Somerset, our ICP is what's called a joint committee in common with the Health and Wellbeing Board. And as you'll be aware, the Health and Wellbeing Boards are a statutory function of the local authority. We've called it the Somerset Board. It has about 35 members on it. It's a very strategic group, but as I say, their purpose is to ensure that that plan or that strategy is delivered. There's a handy link at the bottom of this slide, just in case you want to go and look up what your ICS, ICB looks like in your area. And maybe find out who to contact. But if you have trouble with that, just get back in touch. So when I describe myself, it's quite interesting because even in the introduction, Marie talked about the integrated care system. So when I describe myself and what I do, I say I work across the integrated care system because I work with a range of partners to deliver joint projects across our system. So colleagues from the council, so I work very closely with Clive, for example, who's on the call, from our NHS Trust, with the voluntary community sector, with GP practices, etc. But I'm employed by the ICB. The ICB is my employer. They're called NHS Somerset, which is the logo you see at the top of the slide. And I'm an NHS employee, but I work across our system. So as I said, there's 42 of them in England, and there's a list. So have a look to see, I don't know where people are from, but if you have a look, you can see where you are. And the map, the link is at the bottom here, so you can go to the map. Just for avoidance of doubt, because in my previous life, I used to do recruitment events and stuff, and people had no clue where Somerset was. I'm not saying that that's the case on this call, but we are here. We're number 42 for some reason, we're the last one. And it's that county you probably drive through when you go down to Cornwall and Devon, which are beautiful, by the way, as is Somerset. So I mentioned that all ICSs are different. This is ours. We're often described as a simple system, but we're not simple, really. There's a lot of complexity of working in our system. We have similar challenges to other areas. We do have one Uber NHS Trust, has about 13,000 staff. It encompasses 2 hospitals in Taunton and Yeovil, 12 community hospitals, mental health and community services, And quite uniquely, we even have GP practices across Somerset. That is quite unique in England, because we're covering hospital, community mental health and primary care. From April last year, we also have a single unitary authority via the merger of the old county council and 4 district councils. So we're simple in the fact that our local authority boundary of Somerset is the same as our ICS and ICB boundary. It's one and the same. Whereas for some ICSs, the boundaries cover multiple local authority areas. So if I take BSW, for example, which stands for Bath, Swindon and Wiltshire, which is our neighbouring regional ICS, it has 3 local authorities, and it probably has more than 3 NHS or health trusts in it. Bob is another one, which is Berkshire, Oxfordshire and Buckinghamshire. It's quite a big ICS. It has multiple arrangements there. So you can see they're all quite different and unique in their own rights. So I thought I'd chuck this in. This is our Somerset Health and Social Care workforce. It was done in December 2022, so it's slightly out of date. This is a moving feast. And I would probably say even at the time, this was an underestimate. I would say we probably had nearer 30,000 health and social care employees in our system. This for me is the compelling case about why we need to view our care workforce, our system care workforce, as one workforce. So our role as HR professionals in our system working within the ICS is quite important in terms of shaping, influencing, contributing to our workforce, especially around workforce transformation. So if we're thinking about what does our care workforce need to look like in the future, how could care be delivered in the future? What are our workforce challenges? We might be sharing those workforce challenges. We have a big challenge, shared challenge, for example, between the NHS Trust and our local authority around social work. So we're working together around looking at degree programs, growing our own. You know, that's a key example of a bit of partnership working around our care workforce. I'm not going to go into this in a lot of detail, and I'm sure if you obviously, if you're working and living outside of Somerset, you'll have something similar in your ICS. It'll probably say the similar things. The bit for me is that last paragraph on the right hand side, that actually in order to deliver those outcomes, going back to the purpose wheel, we can only do that together, partners in our system, if we work together. So I mentioned the health and care strategy that is governed and developed by our Integrated Care Partnership for the Integrated Care System. Again, you will have one in your area, in your ICS. And the strategy sets out, again, the needs of the local population and how we will meet those needs, and using a variety of information to underpin it, like the Joint Strategic Needs Assessment, as I said, and many other pieces of evidence. It's, as I said, governed by the ICP. It supports local authority and council plans. So, for example, our forward for our strategy is written and signed by the leader of the council and our chair of our ICB. So it is very much a partnership document, and we have 7 aims on the right hand side, and 4 of those aims I think you'll recognise from that wheel. We've added a couple more. So translating that strategy into what are the workforce requirements from an integrated system point of view, we have a workforce plan. We call it a people plan, and it is owned by our Integrated Care System People Board for Health and Social Care. Now, the People Board is a formal committee of the ICB. So again, our plan has a very strategic prominence across our system in terms of delivering our work and supporting the services that we're delivering to our workforce. You will also have something similar. It might be called something different, but no doubt you'll have something similar. So my question really is, do you know what your system workforce plan looks like? Who sits on your people board? How does it connect to your organisational workforce plans that you're responsible for or you help deliver? how can you feed into the priorities of the system workforce plan? So I think there's just some questions that I'll just throw back to you. We've started and we'll continue to do some work to look at the alignments between all of our organisational people plans in our system to ensure we're not missing out something that should be a system priority. So what's in it for you? This is my sales pitch, really. Why should you get involved? So just as a build up to that, so this is quite interesting. I didn't know some of this information before I started prepping. I kind of knew the numbers were big, but I didn't kind of know the extent of it. So when you start looking at where the money goes for health and social care, it becomes even more important to work collectively around the workforce that supports it. We're talking kind of big bucks here. 1.2 billion spent. Sorry, I just let my dog out. Slight pause. 1.2 billion from a health point of view going into health services, and I think when you add up the council's spend on adult and children's, it's something like 700 million, so it's quite significant. So a lot of money, a significantly sized workforce. On the right hand side, I think if you add up health and social care, the social care stats came from Skills for Care, and they do include local authority care workforce. It's 12% of our economically active population. And we know, so we can have a significant impact on supporting the one population in our area through our workforce. The workforce will need to grow to match our changing demographics. I'm sure we've all got similar challenges, people living longer with more complex needs, early years, for example, the list goes on. So in terms of the why, it's quite blunt to say, but given the financial challenges that we're all facing, given the growing complexity of care needs, given the cost of delivering services, given the workforce challenges that many of us facing, I mentioned the social work challenge before, we can't carry on working in the same way we've always been working, especially with all of that in the background. On workforce, and what will mean is essentially workforce transformation. So we're going to have to work quite differently, and we know, I think I'm preaching to converters, that if we work together, we can reduce duplication. It can feel very fragmented at times. So if we work together, we can work on reducing duplication that will reduce service pressures. We can leverage more opportunities by working together, by building on each other's strengths. I'm a big believer on that. We all bring different skills and different strengths to the table, and that has real power. When that comes together, we're talking about collaborative advantage, and we can create greater impact. And that will ultimately lead to better citizen experience, improved health and wellbeing outcomes, improved efficiency and efficacy. And I don't think anybody could disagree with that. When I went onto the King's Fund website, actually, just to refresh some of the things, I just thought, have I forgotten anything that I could mention? They talk about 3 things that local government's part to play in ICSs. And the first one is talking about joining up health and social care, reducing the fragmentation. The second is the potential, obviously, to improve population health and wellbeing and tackle inequalities. And it's really important to note where the egg comes in, which is what it's more fondly called in Somerset, and I'm sure you've seen similar models. This is from our integrated care strategy. If we're talking about, if you look at the white of the egg, which is actually bigger than the yolk, that is the things that are upstream or in our prevention bucket. They represent the wider determinants of health. So if we get these right, so if you get things like work together on ensuring good housing for people, access to transport, economic development and prosperity, so we're generating more jobs, local areas feel better, regeneration, high quality education. If we get those right, then the yolk will shrink. I mean, it's a bit of an oversimplification, but the point is, surely we need to collaborate and join up our services so we can support people in the heart of their communities, whatever that might look like. No one organisation can do this on their own, as people's health is guided by what's in the white of the egg, not what's necessary in the yolk. And the white of the egg is not necessarily services that health with a big H controls. So that for me is the business case of why we have to work together. We have to work together in terms of working on those wider determinants of health to ensure that we support people to live as long as they can independently in the places where they want to, etc. You know, in delivering. I think if we go back to the previous, well, actually it might be another slide, so I won't confuse things, but you get the gist. So what I want to do is just very quickly take you, now it's zipping all over the place, take you to a case study of some of the work that we're doing in Somerset that demonstrates that really great kind of partnership working. And this is the development of the creation of an academy in Somerset for health and social care. And I think what I was referring to there is in relation to the egg conversation was about supporting that bit around personalised care, about supporting people having the right services in the right place for their needs, available at the right time, delivered by the right people, enabling that one system, one workforce approach. Anyway, this is a case study of where we're working in partnership, in collaboration, and you can see the partners that are listed at the top there that we're working with. And our aim is to provide a space, or the space and access for specialised training provision, an integrated offer to provide a highly skilled, flexible and motivated health and social care workforce, our one workforce vision. And we've been very lucky in Somerset to secure £20 million worth of levelling up funding from DLUC, the Department of Housing, Levelling Up and Communities, to deliver this programme. Most of the money is secured bought two sites to deliver our training vision. Our main site is an old disused grade 2 listed hospital in the centre of Bridgewater, and I'll show you some pictures on the next slide. And the Academy proposition aims to grow and enhance the skills of the health and care sector workforce in Somerset by redeveloping the main derelict hospital into a bespoke high-tech training space. And what it will do, our vision is it will offer facilities such as health and care training rooms, simulation suites, VR technology suites using the latest innovative technology. So we're partnering up with Microsoft and Philips. We'll also have an independent living centre there, and we'll have a learning resource centre. This is very much a partnership programme where, again, I'll go back to that phrase, no one organisation can deliver this on their own, but it has the potential through that partnership to deliver multiple benefits for multiple organisations. And like most areas, this is a response to the growing crisis and concern we have around our care workforce. So we will need to see significant growth in that workforce. So 9,000 more care staff by 2035. Some areas in Somerset's population will see 50% of areas populated by those over the age of 75, come 2035. So by that very nature, the care needs and the complexity of care might increase. We've got significant workforce challenges in terms of recruiting, so adult social care, but also workers supporting children and young people, especially early years. And we do have a depleting younger age population. We don't have a university in Somerset, so people aged between 18 and 24 tend to leave the county for education, and they don't then return till their mid-30s. I was a classic example of doing that, exactly the same. Born in Somerset, left Somerset and came back in my mid-30s. And that leaves significant gaps in the pool of available talent. But lastly, what the Academy is trying to do is to create that parity of esteem, access, consistency, quality training between health and social care. So I have, so yes, the picture. So this is the direct hospital, probably on a good day, I've been told. I have been past it recently. It's not a very pretty site. It's a bit of an eyesore, and it's an iconic building in the centre of what was a thriving town. I've been into the hospital myself when I was younger, visiting people, visiting my cousins. So who was having a baby at the time. So I know the building, and it means a lot to people in that area. What we want to do is turn it into something like you see at the bottom. So something that's quite exciting, and it's generated a lot of excitement and engagement with partners across the system. I won't go into this. This is a care leavers covenant. So the work is being very much led by the council because of their corporate parenting responsibility, but we're getting some funding from NHS England, but again, working in partnership, looking at how we can support care leavers into NHS and social care careers. So you'll have the pack and you'll have this information. I'm not sure how much time I've got. Is that it, Marie?
We're just about at 12:30, Jane. So is that okay?
That's okay. And I'm sorry, I waffled on for far too long. I thought there might be about 5 or 10 minutes for questions, but please contact me if you've got any questions, or I can help demystifying it any further. But it's been great to be part of this webinar. Thank you.
Thank you so much, Jane. I know personally I found out a huge amount from this, which I wasn't aware of. And I loved your slides on the way the different parts of the workforce interact, and the egg analogies really helped me understand those different factors that affect this kind of system. So thank you very much. As I say, unfortunately, not got a huge amount of time left for questions. There are a couple in the chat, which Jane may be able to pick up and respond to. But finally, I say thank you very much for Jane's presentation today. Just a last plug from me. If you haven't seen details of the PPMA's conference this year, do have a look. It's an excellent conference. It's running in Birmingham this year between the 24th and 26th of April. So bookings are still open. Do have a look out for that. So as I said earlier, this is one of a series of PPMA's webinars, so keep an eye out on our website for details of the next one. And I look forward to seeing you again either in person at an event or at one of our webinars. Take care, everybody.